Good afternoon, and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you are using a computer or smartphone connected to the internet, and the audio function is on and the volume is turned up. Please make sure your microphone is muted for the duration of the call unless you are speaking or asking questions. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows after the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman-Bridges and Susan King-Lanier. For closed captioning options, select the closed caption feature on your dashboard. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions and MHSU IDD TBI system announcements and updates. Our focus today is child behavioral health. There will also be time for questions after the presentation. At this time, I would like to turn it over to Kelly Crosby, Director for the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you so much, Dina. Hello, everyone, and thank you so much for joining us today. I'm Kelly Crosby, and I'm the Director of our Division of Mental Health, Developmental Disabilities, and Substance Use Services here in North Carolina. I'm so excited to be joined by guests today, and I'm actually going to turn the mic over to our first guest, Yvonne Copeland.
Thank you, Kelly. I'm Yvonne Copeland. I'm the Director of the Division of Child and Family Wellbeing, and I'm really happy to be here today. In addition to what you see on the slide, I just want to share that I am a family member of adults with mental health, IDD, and substance use issues. So I get this from a very practical, lived way, as well as from administering these great programs. And the majority of my career has been spent, in my North Carolina career has been spent with the LME MCOs, working alongside of them with the Department of Health and Human Services. And again, I'm happy to be here. I'm going to pass it to Heather.
Thank you, Yvonne. Good afternoon, everyone. Heather McAllister. I'm the Family First Prevention Services Manager for the Division of Social Services. I'm really happy to be here today. This is a long-time passion of mine to see us at a place where we're really targeting and looking at how to best spend these investments to meet the needs of the children, youth, and families that we serve. Thank you.
Thanks so much, Heather. So first, I'm going to do some system updates, but I just want to remind folks that the focus of today is actually going to be our new investments in child and family behavioral health. And it's very exciting. Our secretary, one of the things he says all the time, and he puts in his signature, is one DHHS, and we are one DHHS. And I'm so excited to be here with my sister divisions, Division of Child and Family Wellbeing and Division of Social Services, because this is a true partnership. All right, so I'm going to give some quick system updates. This month is very exciting. We've had a lot of big things happen, and we have a lot of big things coming up in the system. So the first thing I wanted to highlight on the next slide is our meetings that are happening this month. So today we are featuring child behavioral health. You will see our routine meetings that we have with consumers, LMEs, providers, and our hospitals. You'll see the dates of those meetings. If you are interested in being any of those groups, go ahead and click the form button and we'll make sure you get that invitation. We also have all of our standing advisory work groups that we have convened around financing, around the new $835 million we got from the General Assembly. You'll notice the Child Behavioral Health Group starts the 15th. So that's our newest advisory group, and we're kicking that off with today's seminar. Remember, there's a hot link in here for the form if you want to sign up for any of these advisory groups. Next slide. So in April, we will be having our wonderful colleagues from the State Medicaid Agency come on to talk about tailored plan launch. And what you're going to get today is a little taste of the slides. We've been working hard in partnership with our CFAC, with consumers and families, with Medicaid, on making sure that we had communications that were easier to understand for consumers and families. So we're working on all of that right now. And you're going to start to get a little taste of those on these webinars today. So here's a little bit. So why is it important for you to come next month? It's always important for you to come because we tried to make these meaningful to you so you can learn more about what's happening in our public mental health, substance use, IDD, and TBI systems. Next month is all about tailored plans. So remember, tailored plans are incredibly important to understand if you happen to have Medicaid or you've got a loved one or friend who's on Medicaid, or even people that you work with who are on Medicaid. And tailored plans are specifically for people who've been diagnosed with a severe mental health issue, a substance use disorder, intellectual or developmental disability, or traumatic brain injury. I always tell people all the time, tailored plans are LMEs. They are LMEs, but they're a little bit different than the way LMEs have worked in the past. Now, remember, tailored plans have been delayed several times because we wanted to make sure we had everything right. But we are mandated to go live July 1st. We're ready to go July 1st. So there's a lot of information we will be sharing with you here and via other channels. So you can get yourself, your loved one, your friend, your colleague, the people you support ready for this change. One of the things we will be talking about in April is something called choice period, where people who are on Medicaid about to go into a tailored plan will be able to choose their primary care provider, because we want everybody to have a primary care provider. If it's a family doc, if it's a pediatrician, if it's an internist, we want to make sure that everyone has a place to go for basic primary care. We want everyone to be really healthy. Next slide. So what is a tailored plan? Tailored plans are a new kind of Medicaid plan. If you have Medicaid, you're still going to have Medicaid. You're still going to get the same primary care, specialty care, pharmacy, behavioral health care that you used to get. But now where people get their physical health care and prescriptions from Medicaid and their behavioral health, mental health, substance use, IDD services from an LME, you're going to get it all from the LME now. LMEs are going to operate something called tailored plans. That's their Medicaid health plan hat that they wear, but it is the LMEs that you know and love, okay? As a reminder, tailored plans are specifically for people with severe mental health issues, substance use issues, intellectual and developmental disabilities, and traumatic brain injury. Next slide. Tailored plans are a little bit different than the basic Medicaid thing that we call a standard plan. So there's a lot of people right now in managed care in Medicaid. Most people in Medicaid right now are getting something from a standard plan. Those are from health companies like Healthy Blue, WellCare, United, AmeriHealth, Carolina Complete Health. So those are some of the standard plans, and that's basic Medicaid services, doctor's visits, basic behavioral health outpatient benefits, prescription drugs, vision services. So a lot of people in Medicaid are already in a plan called a standard plan. If you're one of the folks maybe listening today, or one of the folks that have, again, an intellectual or developmental disability, severe substance use disorder, you might be getting a letter in the mail saying you are joining a tailored plan. Remember, your tailored plan is an LME. And that letter is going to tell you that the LME will continue to make sure you're getting your mental health, substance use, IDD, or TBI services. In addition, they're going to help make sure that you get your medical services as well. So the tailored plan is a little bit different than your standard Medicaid plan. So tailored plan has the same thing that a standard plan has, all the same services that I said, but there are unique services for mental health. There are unique services like the innovations waiver, or our 1915 I-option services, or traumatic brain injury services, as well as state-funded services that are very specific to tailored plans, just like they are today with LME MCOs. So again, we'll be having a whole deep dive on this next Thursday. You'll be getting more information. Folks have had lots of information over the years about tailored plans, but it's our job to make sure that we're doing our very best to answer questions and make sure you understand when you start getting letters in the mail about joining a tailored plan. Next slide. All right, super exciting. This month is Brain Injury Awareness Month. Did you know that we provide services to over 40,000 individuals with traumatic brain injury here in North Carolina? We would like to do more. And what's really cool is that the General Assembly gave us authority to expand the TBI waiver. So right now, I think only 6 or 7 counties are covered under the TBI waiver. It's a lot like the innovations waiver. It's services and supports, a whole package of them for individuals with traumatic brain injury. We're going to be able to expand that statewide. It's coming. We also got authority for additional Medicaid services for people with traumatic brain injury. They are called 1915 I-option services. You've probably heard that term, but it does mean we can provide more Medicaid covered services to people with traumatic brain injury. You've heard us talk here about it. We'll talk about it more, but currently we're funding re-entry services for people with traumatic brain injury. So if someone who's incarcerated with traumatic brain injury, we make sure they are able to return to the community and get good wraparound connection to services when they return to the community. So we're expanding that with some of our new legislative dollars. And we do currently get money for state funded. So for people that don't have Medicaid, to provide additional services for people with traumatic brain injury. And we are always asking for more. We partner with lots of folks in the state, but we do have our Brain Injury Association of North Carolina, which is our statewide advisory group. And there's a hot link here if you're interested in learning more about the BIAC. Next slide, please. Because it is also Intellectual and Developmental Disabilities Awareness Month. Here's some really important statistics. Over 200,000 people in the state are diagnosed with intellectual developmental disabilities, and about 7% of children under the age of 18 are diagnosed with intellectual and developmental disabilities. Many families, including mine, have folks with intellectual and developmental disabilities in their family. They're part of our communities and part of our lives. So let's celebrate them and let's make sure people are more aware of the services and supports available, and are thinking about inclusion every single day. We want to make sure that folks with intellectual and developmental disabilities are well supported and included in every facet of life. So if you want to know more, we do have a few lunch and learns this week, which are really exciting this month, March 13th. So next week, we have our IDD Awareness Month Lunch and Learn. And this is cool because it's a partnership with the North Carolina Council on Developmental Disabilities and our own office here of Diversity, Equity, Inclusion, DMH, DDSUS, DHB will be there. So it's great. It's all of us celebrating IDD Awareness Month. Towards the end of the month, we also have our routine Inclusion Works Lunch and Learn. If you don't remember what Inclusion Works is, it's our effort to make sure that we are creating more inclusive work opportunities for people with intellectual and developmental disabilities who want to work in integrated settings and should have the right to work where they want to work, when they want to work, have opportunities for advancement, benefits, and good wages like everyone else. So we're having our Inclusion Works Lunch and Learn. We have those every month. Our next one is coming up around March 25th. We're doing a lot in the IDD space, and I'm sure that we'll have a session very soon about some of our efforts, in particular around direct support professionals. We have an advisory group right now. Some of you may be involved in it, and we are very dedicated to making sure that in addition to rate increases, we're doing other things to create career pathways, pipelines for careers, incentive programs, good ability for individuals with IDD and their families to match to direct support professionals. So we're trying to do a lot more to make sure people know about direct support professional as a profession. They want to stay in it, and there's opportunity for career advancement. So we're doing a lot in that space. So stay tuned for more information. Next slide. Big announcement. Hopefully you saw our press release and everything else. We launched the Peer Warm Line on February 20th. Huge labor of love. And I have to thank Shireen Carrico and Promise Resource Network out of Mecklenburg, although they're all over the state. My own team, Lisa DeChantis in particular, and her team, and all of the wonderful peers that support all of us across the state every day. We're so excited about the Peer Warm Line. It is 24/7, 365. Anyone can call. It's 1-855-PEERS-NC. So hopefully it's an easily understandable number. You can call and speak to a peer at any time. You can also call 988 and they will do a warm handoff to the Peer Warm Line if that's what you choose. If you call and you decide, hey, I would love to talk with someone with lived experience who can help me navigate the system or who can understand what it is that I'm going through and maybe help me with their own recovery, you can call the Pure Warm line. Anytime 988 can transfer you to the Pure Warm line. So super excited about that, and grateful for the partnership with PRN, with our state CFAC, and with all the incredible peer agencies across the state. Next slide, please. All right. So once again, we're going to recap where we are with our investments that we are working on this year and next year through the generous contribution of the General Assembly. Next slide. We've talked about rate increases for behavioral health providers. We've talked about crisis system investments, justice investments, some workforce. We had DSPs, direct support professionals, and peers in our last two side-by-side sessions. So today, we're doing an overview of our last big area of investment, which is child and family well-being. Now, it doesn't mean we're not going to come back to the other things. Of course we are. We've been meeting with our advisory groups, gathering lots of information, coming up with recommendations for spending, and you will start to see some of those being discussed here in side-by-side in advisory groups. So we're ready to, over the next couple of months, get some announcements about things we are going to invest in and continue to support in our system. But today's about child and family well-being. Next slide. So here's our goals around investing in behavioral health for children. So we've spent time, and we know what some of the critical system needs are in our system. And we have identified some very specific outcomes that we're hoping to achieve with this $80 million. First, we want to prevent children from having a behavioral health crisis or unnecessarily using the emergency room. We want to make sure that the behavioral health needs of children are quickly and accurately identified. We want to keep children in the home whenever possible with wraparound services, so home-like environment, community-based services. But we do want to increase access to high-quality residential options for children who do need an out-of-home placement. We'll talk more about that later on. Next slide. I'm going to hand this over now for a deeper dive to Yvonne Copeland.
Thank you, Kelly. Thank you. So as Kelly said, I'm going to do a bit of a deeper dive, or really an overview, on the child behavioral health investments. Next slide, please. So our goal is to really fill the gaps, right, in this child behavioral health system so children can receive the services that they need in a timely manner, just as Kelly said. Considering that the $80 million is a one-time investment or non-recurring, we've had to prioritize a particular population. And we decided to prioritize a population where we can probably see the greatest impact. And those are children staying in EDs and DSS offices. So we're also looking at a few outcomes we expect to see as a result of this investment. And those are fewer ED visits, fewer children staying in DSS and EDs, fewer readmissions in out-of-home placements, shorter length of stay in those out-of-home placements, and more children with behavioral health needs living in home settings. Next slide, please. So here, we seek to increase the treatment options for children, especially those, again, at risk of staying in DSS and EDs. So we've prioritized our investment areas, and they are noted on the slide: community-based services, foster care behavioral health continuum. We want to expand that. We want to expand family-type placements so that there are more options, and we want to expand residential and facility-based services. In particular, we're directing significant investment in the creation and expansion of family-type placements, such as intensive alternative family treatment and therapeutic foster care. This will help us increase access to these services and, again, mitigate or alleviate our need, or the phenomenon that we see with children in DSS and EDs. We're also using a number of approaches for this strategy. We're recruiting new homes to serve children with complex needs. We're supporting existing homes with getting to yes, making sure that they accept what do they need, what supports do they need to accept children with complex needs or co-occurring co-occurring needs. And also creating family setting options like emergency placements to avoid or reduce our reliance on ED and DSS stays. Next slide, please. Here we see a sort of depiction of the child behavioral health array of services. The light blue rectangles represent areas where we're making investments. So we're making a lot of investments, as you can see. And those investments are where we're trying to fill gaps, trying to strengthen or fortify the system. And essentially what we want to see here is we want to see ourselves serving more children on the left-hand side, right? Intervening earlier so that they don't need the more intensive services unless they truly, in fact, need them as a result of their condition and not just a lack of service and a lack of care. Next slide, please. And this is a great announcement as well. This doesn't have to do with the $80 million advancement, but it's a win. We all want to celebrate. And we recently, the Department of Health and Human Services recently released the external facing child behavioral health dashboard that launched on February 1st. And what the dashboard does is it gives us all, you and us, visibility into what is happening in the child behavioral health system. We are able to look and see where there are gaps in services, where are the disparities, as we can drill down on the metrics and see, look at children that are being served by geography or by gender identification, by race. So we can see who's being served, who's not being served, and possibly identify where we need to lean in. And again, this is about visibility for all, transparency, and it also provides an opportunity for us to hold one another accountable for where things need to be happening. We know where we need to lean in. Next slide, please. And I believe this is my last slide, and this sort of just gives you the metrics that you're able to see if you are to visit, and I encourage you to visit the Child Behavioral Health Dashboard. And you see the metrics there, you see the data source. We can look at, the number of children diagnosed with certain conditions that we see are prevalent. Also, we can look in the schools. That's something that we're really committed to do, is meeting children where they are. So we want to see what's happening in a self-reported survey, the Youth Risk Behavioral Health Survey, what some of those metrics are looking like. And we want to get as far upstream as possible. So we even have a metric for early childhood. So this is going to help us know what to do with our current and future investments, this visibility, and hopefully we'll be doing that in concert with you. And I believe that that is my last slide. And yes, I'm going to pass it to Heather.
Thanks, Yvonne. So this afternoon, I'm going to be covering the specific investments we're making targeted to meet the behavioral health needs of children and youth in foster care. It is important to note that special considerations need to be made for this population, because children and youth in foster care are identified as children with special health care needs by the American Academy of Pediatrics, because they often enter foster care with unidentified and or unmet needs, and they have experienced trauma as it relates to their experiences. These experiences can have a number of impacts on these children, including increased behavioral health needs, which can impact the stability of placements. And if not identified and treated early, we see a lot of placement instability and moving further up the intensity of behavioral health treatment, including restrictive care. The services I'm going to review fall within the foster care behavioral health continuum section that Yvonne reviewed. And when implemented, will build capacity for DSS managed crisis stabilization and assessment placements. All right, next slide. So the current state or primary problem, how did we get where we are with determining where to invest these new funds? We were looking to solve a specific problem. As many folks know and hear, that there are children and youth who are unable to access community-based placements or treatment placements post hospitalization or entry into foster care, or if discharged from placements where their needs aren't being met. We're looking to address the specific needs of children who are ED and ED's boarding, right? And this is data that's reported from our LME MCOs, where we can see there's an average of 54 children who are boarding in an ED each week. Of those, 40% are in DSS custody and 26% have co-occurring IDD and behavioral health needs. We also have a significant number of children at any given time who are staying in our county departments of social services offices. These children are boarding both in DSS office and other settings, often awaiting clinical assessments and other things to help to identify what their needs are and where they'll be most successful. All right, next slide. So in looking at the continuum, as you can see across this chart, we're starting with the lowest or least restrictive settings for children, looking through from respite to kinship foster care, therapeutic foster care, group homes, and then psychiatric residential. The services that we are looking to invest in are the Emergency Placement Fund. And this is, the goal of this is to reduce the number of children with behavioral needs that are without placement, staying in local DSS offices, or to prevent them from being in DSS offices. This provides our local departments of social services with funds to develop local solutions to meet these children's placement needs. This was based upon an effective models both in North Carolina and Virginia, and the money is actually going out to DSSs now. There's some cost allocation, and DSSs are able to implement those practices in their communities that show better placements for children with complex behavioral health needs. These funds can be used to maintain a crisis placement provider on retainer who can provide temporary emergency placements suitable to meet the child's needs until treatment can be located. They can provide short-term rate increases to placement providers who care for children with behavioral needs who require an exceptional level of supervision. They can also be used to improve placement providers' ability to meet a child's individual needs. Implementing these local solutions is really important. And, again, it will reduce the number of nights that children will stay in DSS offices awaiting appropriate placement for behavioral health treatment. The other services we're looking at, so if you think about that, that is, again, to meet that immediate need of having children not remain in DSS offices. The other investment we will be making is in professional foster parenting. We currently have a pilot that has shown good results. The professional parenting model is an evidence-based practice. It has trained parents and the children are living in family type settings. It stabilizes children by providing therapeutic and other supports, helps maintain a connections with their family, and supports reunification. Early reports from our pilot shows they have success with both stabilization and reunification for children. And then lastly, we're investing in Placement First Plus. Placement First Plus and stabilization is a model that was originally brought to us by DSS directors who'd come together to identify what would help solve this issue at the local level of children remaining in DSS offices, and also children who were very challenged to achieve stability in placement and had frequent moves. This model is designed to meet the needs, again, of children in offices without placement. And it seeks first to have a child have a place to live while their needs are being identified and interventions are being provided to help stabilize them so they can successfully transition to family type settings with those identified supports in place. The transitions from the Placement First Plus could be to kinship care, foster care, or reunifying with their parents or if necessary, other therapeutic treatment settings. All right. I'm going to talk about another wonderful program that we're looking to increase access to. And so if we could move to the next slide. Oh, I'm sorry, I skipped one. All right. So other work we're doing in beyond the behavioral health investments, and folks may or may not be aware of this in their communities, but the division has also implemented kinship care payments. We talk a lot about least restrictive settings when children enter foster care, and we have an emphasis in North Carolina on a kin first culture where we place with kin whenever we can as a first choice. To support those kin, there are kinship care payments now available, and this new policy provides payments to kinship care providers who take care of children who are in the custody of DSS. Kin are defined as a person who is related by blood, marriage, or adoption to a child and is providing foster care. When children cannot be assured safety in their own homes, often the best alternative resource can be found with extended family and other kin. Kinship care providers will receive a stipend of $405 or up to $405 per month for each child in their care. Before now, most county departments of social services were not able to provide this type of support to their kinship families. These payments will provide financial support and promote placement with appropriate kinship care providers for children in foster care. Ultimately, we believe this will have a positive impact on permanency outcomes for children and lead to children exiting from foster care to adoption, guardianship, or reunification sooner. So this is again, it's a continuum, right? If we think about all of the services our children in foster care need. All right, now I'm going to move to intensive alternative family treatment. Thank you. All right, so we're pulling another service of focus out, this IAFT. We know that with the right supports, many children can be more successful in family type settings than facility-based care. However, we also know that we've seen a reduction in the availability of family type settings over several years. And additionally, some youth do require more intensive support to be safe and successful in those family type settings. The other services that Yvonne highlighted in her section that are being expanded with this new funding will support more children being placed in family type settings. We are making strategic investments in intensive alternative family treatment to both increase the availability and quality of family type therapeutic placements. So children are served in the family type setting with staff who are equipped to address their specific and individual needs. The department will work with IAFT, provider agencies, payers, current and former foster parents, and others as we move forward with the design of this work, strengthening the provider networks who deliver this service. All right, I'm going to turn it over to Kelly. Thank you.
I'm muted. Thanks so much, Heather and Yvonne. And so now I'm going to add on to what Heather and Yvonne said by talking about really the deep end of the child behavioral health continuum, which is the child behavioral health residential system. Now, as a quick reminder, I want to draw your attention back to something that we talked about a few months ago and are actively working on. And Yvonne mentioned this in her slides too. As a reminder, we're also doing work around the crisis continuum here in North Carolina, and that absolutely will affect children and adolescents. Remember, the goal is to try to keep kids at home, to de-escalate and manage crisis and get people connected to aftercare services. And if a child does have to go somewhere for crisis, could it be a crisis urgent care, a behavioral health urgent care, or a crisis receiving facility in the community? So keep that in mind, that we are also working on that crisis system and absolutely for how it supports children, adolescents, and families. And we'll be bringing back more recommendations on the crisis system. But let's talk about the child behavioral health residential system right now. On the next slide, you're going to see, hopefully folks remember this. Hopefully you're looking at this every month. This is one of the metrics on our LME MCO dashboard. And these are Medicaid children who are in psychiatric residential treatment facilities. Big name, PRTFs. On my next slide, I'm going to talk about all the levels of residential care. PRTF is our highest level of residential care. And one of the things that we track every month with our LME MCOs in partnership and across the department is the number of children in PRTF. Now, as a reminder, that doesn't mean if it's good or bad. It's a number, but it's an important number for us to track to see if we're going up or down, because the goal always in any system of care, especially for children and adolescents and families, is to reduce out-of-home placement. So what we're looking for are things like trends of kids, fewer children being in PRTFs, shorter lengths of stay, fewer readmissions to PRTFs. But for now, this is a dashboard look. It's a dashboard look. So remember, a dashboard snapshot is just month over month telling us a number that we have of kids in this highest level of treatment. And it's broken out by LME MCO. And you will see our most recent data, which is a quarter of data, runs through from August through October of 2023. There's always a significant data lag. It has all of the original 6 LME MCOs in it. So the next time you see this, or the next few times you see it, the data will continue to be refreshed and it will look different because the LME MCOs now are 4. And Trillium in particular has picked up a lot of new counties. So the data will look different, but I want to remind folks to be looking at this all the time. And I'm going to tell you how to read it again. I told you this back in October, but I'm going to tell you how to read it again. So on the left-hand side, you see data from the 6 original LME MCOs. And this is the number of children per 10,000 children who have Medicaid in their catchment area, because the LMEs continue to be all different sizes, county numbers. So we want to try to make the data a little more easy to compare. So on the left-hand side, you will see per 10,000 children in Medicaid in their LME region, how many of those kids are in a PRTF level of care. And so you see it varies greatly. And you see that Sandhills was a big outlier. It had definitely per 10,000 children, the most children in PRTF. So that left-hand side is pretty important. It's a way to try to compare areas to one another. On the right-hand side, you will see that we're taking those, the pure numbers of kids in PRTF and trying to break it down so we understand a little bit more what we're looking at. So let's just look at the first one. Let's look at Alliance. Alliance is the first group of blocks, okay? So overall, there's 112 children in Alliance's catchment area in PRTF, psychiatric residential treatment facilities. Of those, if you look on the left-hand side, we look at, are they in DSS involved or not DSS involved? So you'll see 42, that kind of dark yellow color who are DSS involved, and the dark blue who are not DSS involved, because it's important for us to understand the dynamics of the children in PRTFs. On the right-hand side, we also want to know where those kids are. Are they in state? Are they out of state? Are they in a border facility? So in Alliance, the darkest orange are the children who are truly out of state. So they are definitely out of state and more than 40 miles away. That's our boundary, more than 40 miles away. So 18 children are really somewhere else in the United States. 38 children are in a border facility. And so for a place like Alliance, remember Alliance has Mecklenburg, a lot of those children are quite likely right over the border in South Carolina, which for many families is actually quite closer to them, right? So we're always trying to think when a child is in a residential facility, let's try to keep them as close to home as possible. And for children in Mecklenburg County, sometimes that really is South Carolina. So we know that 38 for children are in a border state within 40 miles of North Carolina, and the other 56 are in state. So that's just how you read this. But again, remember, we're tracking children in PRTF every month. On our LME MCO dashboard, we're also tracking children in ED and DSS settings. So Yvonne showed you the metric on the child behavioral health dashboard. We're also tracking that by LME MCO. So remember to look at that every month. I think in the hot topics, we flag when we post a new dashboard every month. Okay, next slide. So this is a big slide. This is telling you all about the array of residential services that we have. And you may be on the call, you may be very familiar, you may not be familiar. But we have a lot of levels of residential care here. A lot of words on this slide, but we basically think about residential levels of care from like low level of need to the most intense level of need, which is PRTF. So we have things on the low end of the continuum like foster care and treatment foster care. It's what it sounds like. It's foster care 24/7. You're living in a home setting though, And treatment foster care or therapeutic foster care has that additional level of wraparound therapeutic supports for the child in the foster home for both the foster parents and of course for the child. Then we have residential levels of care, and those are group homes, but they're therapeutic group homes. And they're everything from level 2 program type to level 3 to level 4. So all along the continuum, we have level 2 family, level 2 program, level 3 program, level 4 program. And just think about 2 through 4. Up at 4, we also have secure lock facilities. So these are children in a group home setting, again, 24/7, getting therapeutic wraparound therapy, supports, psychiatry services, therapy with the family. And it depends on the needs of the child, whether they meet criteria to be in a level 2, 3, 4, or need a locked facility. So it's about how acute and the needs are of the child. But they're essentially group home settings typically where there's therapeutic wraparound services provided in that setting. Then we have psychiatric residential treatment facility, and it really is like inpatient hospital, but it's long-term. It's not a 7-day stay in a community inpatient setting. It is a longer-term stay. So it's not acute, it's not crisis, but it is someone that needs very intensive therapy, medications, and support 24/7. So they need a therapeutic environment. And we'll talk a lot about that in the next couple of slides. So it's the most intensive level of care that we have right now. And then, of course, we always have inpatient psychiatry, or I'm sorry, inpatient psychiatric hospitalization, community hospitals, even in our state facilities, for when someone has an acute issue. Acute meaning it's urgent now. The person is a threat to hurting themselves or others. And they need to be stabilized and managed in a hospital setting. All right, next slide. So a lot of words, but just think the idea is a child needs a certain level of support. So they either need treatment, foster care, therapeutic foster care with wraparound supports, clear up to this really intense PRTF. So part of our issue is that with residential treatment, high quality residential treatment is not always available to youth who need it when and where they need it. The map's kind of small, but you already heard some statistics. Over 50 children sleep in EDs and DSS offices, and a lot of that's due to lack of availability of residential treatment options. Now, in order to even need a residential treatment option, I just want to back out of that a little bit, just to make sure that we unpack it. It means that the child's behavioral health needs, right, their mental health needs are that significant that they can't be home with wraparound community-based services. They do need an out-of-home level of care, and that's pretty acute. And so these children have been diagnosed as such, and sometimes they're waiting in emergency rooms or DSSs to get the level of care that their assessment by a clinician says that they needed. Now, here's another thing that I want folks to think about is youth do finish their time in PRTFs. We want them to. We want it to be as quick as possible, actually. But a portion of the children who go to PRTFs do go to lower levels of care, right? Sometimes they go to a level 3 or go to a therapeutic foster home to go home with wraparound supports or go home with wraparound supports. But a quarter of children either go to another PRTF, so that PRTF and the child, they were not having their needs met there, they were not progressing there, and so they went to another PRTF, or they go home with no services at all. And that happens. Sometimes children are discharged from PRTFs, and we are not always good about making sure that they have the right wraparound services. So there are some problems that I'm highlighting that we want to address, okay? Now, if you look at the map, most of our PRTFs in our level 4 are concentrated in one area of the state. Look where they're all concentrated. And why is that a problem? The problem is if you're not in this area of the state and you're a child or your child needs PRTF level of care, it often means they're going very far afield from home, which makes it hard for families to stay in touch, for DSS caseworkers to stay in touch, to make sure that the child is firmly rooted in the community, because that's what we want from day one. We want transition planning back into the community to be planned from day one. And these are children. We want them to have friends, loved ones, and families visiting them as much as possible. So even the placement of our residential facilities right now, specifically our PRTFs in level 4, so our highest needs are really clustered in the state. And that can make it really challenging to have that home connection for a lot of kids if they go to a PRTF. Now, roughly 35% of children and adolescents are in and out of state PRTF. And our data shows that children in foster care are more likely to be sent out of state than children not in foster care. And that takes it's a complex issue. But one of the things that we do know is we have PRTFs clustered. We do know we have more children in DSS custody going out of state. And some of that is due to the very specialized needs of children in foster care and the specialized needs of kids in all kids in foster care, kids not in foster care. So if you look at the next slide, I want to unpack that a little bit, kind of the specialized needs and why we're having some of these issues. I want to do a comparison for you. So if you look at the left-hand side, you're going to see the number of therapeutic foster home beds. That's kind of like our lowest level of care if a child needs to be placed out of home. And so if you look at kind of the pale tan bar, we have lots of licensed homes. So in theory, we have lots of availability. But if you look at the yellow line, we're not really using our therapeutic foster care availability as much as apparently we have capacity, right? So we're not often using that lowest level of care. Now, if you look at the right-hand side, here's some statistics around PRTFs. So if you look at the top line of the graph, we are in year 2023, excuse me. We currently have 27 PRTF facilities with 339 beds. If you look down the chart, you'll see past years, we have fewer facilities and much fewer beds. Now, the thing that I want to suggest to you is not, oh no, we don't have enough beds. That's not what I'm suggesting. I'm suggesting that we focus on quality rather than quantity. I'm not saying we don't have enough beds. I am saying that most of the PRTF beds we have aren't maybe not as specialized as some of the needs we're finding in North Carolina with some of these children who are in emergency departments and DSSs. So, for example, some of the children that get stuck or turned down from some PRTFs have more complex issues. So it might be a child with an intellectual and developmental disability and a mental health issue, or a child with an eating disorder, or a very young child who maybe has some externalizing behaviors. So there are children with very significant levels of need, often with very significant levels of trauma, often with very significant complex needs or diagnoses. And it can be very hard in state if we don't have specialized care for those children in particular. So again, we're not necessarily saying we need a lot more beds in North Carolina and that's the problem. Part of the problem really is making sure that we have quality, we have enough specialized settings for kids. So a lot of times kids that have special needs or need particular programs, like some of our younger children with dual diagnosis, children with eating disorders, children with significant trauma, they end up going out of state because they have specialized facilities where North Carolina might not. So knowing that as we think through our strategy, we need to think through what is the kind of capacity we need to build. And even when you look at the therapeutic foster care, right? You have to think about what is the level of a child needs, and do we have along the continuum the right level of care and the specialized treatment that children need across that continuum of care? Next slide. So the last thing I'm going to say is our residential level of care goals. And I hope that you've heard from Yvonne, from Heather, and I kind of that same thing. We don't want children in emergency rooms. We don't want them, emergency rooms are necessary, right? We all need an emergency room sometime in our lives, unfortunately. It's part of life. They pay such a valuable service for all of us. But we don't want children getting stuck there. That is not a substitute for treatment, and it is not a substitute for housing when we're looking for a higher level of care or a residential treatment facility. So these should not be temporary residential settings for children. We want to make sure that we have a nice crisis and also respite options to support children, their families, and their systems. So we need appropriate community-based crisis settings for children that are small, home-like, therapeutic, and trauma-informed. It's not just it's a phrase. Imagine if you're a child going through crisis settings and being displaced from your home, and you might have a whole bunch of other trauma in your life. We need to make sure that we have therapeutic, safe, trauma-informed settings for kids. Those are crisis settings, but they're also respite settings. Sometimes children need a break. Sometimes their caregivers need a break. So we need respite centers so everyone can calm down, get some treatment, get some support, and get the wraparound they need to be successful so problems don't escalate. Okay. We also need to increase access to specialty in-state residential care for children. You're going to hear me say this a lot. It should be brief, it should be therapeutic, and it should be home-like. We all want children to be in homes. Sometimes children need residential level of care. We want those to be only when absolutely necessary. We want it to be a trauma-informed home-like environment. We want it to be brief. These are treatment settings. They are not living settings for life. They are brief treatment settings for children. We want to make sure they're high caliber and quality and that the child receives the much needed treatment that they need. But we also want to make sure that those necessary transitions back to their families and communities happen successfully. And that always means from the moment a child is admitted to your residential facility, they're getting therapy, they're getting family therapy, they are planning for discharge back into the community. So they're back on track with education, whatever clinical supports they need in community, friendships in the community. We want children to transition successfully back into the community. All right, next slide. As a reminder, our new Child Behavioral Health Advisory Committee starts on the 15th. I think we've given you a lot to talk about. All of us across the department share a part of making sure the needs of children and families are being met. I'm so pleased to partner with Heather and Lisa and Susan and the wonderful folks at DSS and Yvonne and Sharon and her awesome team at DCFW and our awesome team here at DMHDDSUS and our Medicaid colleagues as well. So I'm super excited to partner across this. It is a lot of material we cover today and a lot of things we'll cover in the advisory meeting because we need to really focus on the full continuum of care to make sure that we are investing smartly and meeting the needs of children and families in our state. You'll see a hot link in here so you can register if you're interested in the child behavioral health meeting. And that might be one of the committees. We need a lot of subcommittees because there's a lot of ground to cover. Next slide. All right, so we've got time for Q&A. We have time today.
We do. So thank you, Yvonne, Heather, and Kelly for sharing so much great information with us. So Yvonne, my first question is for you. So how will the funding that you spoke about earlier support children with IDD?
That's a very good question. And actually, the specialty services that we're talking about building, particularly with IAFT, some of the other services where we're looking for out-of-home placements or people who are just providing support to children that are in home are going to focus on co-occurring needs, right? So they're going to focus on children with behavioral health and IDD needs. So we're trying to build that capacity. It is woefully lacking right now, right? That's what Kelly spoke about, you know, so we are looking to build that capacity by providing supports to providers, right? We're going to support providers in building that capacity so that we can serve children.
Thank you, Yvonne. Heather, next question is for you. What safety measures are being implemented to help ensure the kinship family are safe places?
So again, when we place children and youth who are in the care of or in the custody of county departments of social services, there are assessments that are being made with homes, right, to ensure that the homes are safe and appropriate for the children and that the parents who will be caring for the children have the skills and or resources necessary for just parent them, right, to meet their needs. And so again, you know, where will be perhaps identification of specific needs a child may have and supporting referrals, right, to different services, as well as regular communications with the caregiver and the regular visitation with children with the social workers to ensure that things are going well and that needs are identified early and that resources are brought to the family.
Thank you. And Heather, actually, one more question for you.
Sure.
What supports are provided to the DSS caseworkers who experience trauma through their caseload?
Sure. So secondary traumatic stress through many fields of work, including child welfare, is a reality. And we have resources available, whether it be trainings or supports for supervisors to learn how to support their child welfare workers, available on NCSW Learn, which is our child welfare learning platform. We also have on contract the Center for Child and Family Health, which is the National Child Traumatic Stress Network site here in the Raleigh-Durham area. And they can work with any county DSS that seeks help to address secondary traumatic stress and come up with some interventions that can be helpful for staff if needed.
Thank you, Heather. That's wonderful. That was our last question that came in. I want to see maybe Kelly. I see you came up.
Yeah. There were so many good, and Elliot flagged for me behind the scenes. There are so many good questions. And thanks to Yvonne for that answer about families who have loved ones with intellectual and developmental disabilities. So as a reminder, today we were talking about services for children and youth, and that, of course, is inclusive of children with intellectual and developmental disabilities. There are, as Yvonne mentioned, there's a lot of training and support, and we want to make sure we have adequate networks for folks to address the needs of individuals with intellectual and developmental disabilities and mental health issues. It's really important to remember everyone has mental health issues, everyone. Lots of people can experience trauma. And we need to make sure that for children and adolescents with intellectual and developmental disabilities, that we are aware of, and we have a well-trained group of clinicians and treatment providers who know how to meet the unique mental health and sometimes traumatic experience needs of people with intellectual and developmental disabilities. We've also been asked about direct support professionals and the services, the other service needs for folks with intellectual and developmental disabilities. Today, we focus very heavily on mental health and substance use supports. We got asked about the two. Absolutely, this is about substance use supports too. But we are absolutely working on just home and community-based services for individuals with intellectual and developmental disabilities as well. And those are typically the services provided by direct support professionals. So whether you have an innovations waiver slot, whether you're on the waiting list and you can get state funded or Medicaid funded services like respite, like community living supports, like supported employment. Part of what we talked about last month was, in addition to rate increases to get more direct support professionals, i.e. more services, what else are we doing to make sure that we're recruiting, retaining, creating more direct support professionals? So we have a wonderful benefit now. We have more services, but we need workers to provide those services. So that was part about what we talked about last month. And I think one more thing I'll mention is folks asked about crisis services for people with IDD. So absolutely, we're trying to build the most inclusive crisis system we can. And when we revisit crisis here again, we'll talk more about that. And someone raised NC Start. Kathy talked about NC Start, which is a wonderful program. And we are absolutely looking for expansion of NC Start, which is a very specific respite kind of crisis skill building family for a program for people with intellectual and developmental disabilities and their families. We're absolutely looking at expanding that model with our crisis dollars as well. So Elliot, that's about sums up our big buckets of questions, right? Okay.
It does. Thank you.
All right. So do we turn this back over to you, Dina?
Yes, thank you.
Thank you.
If we did not get an opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posted on our community engagement and training page. There will be a brief survey following today's webinar, and we would appreciate your time completing it. Our next side-by-side webinar is scheduled for Monday, April 1st from 2 to 3. This concludes our webinar for today. Thank you for attending.